Hello everyone, welcome to the next Saviours of Essential Question Series NEET PG 2025. Today we are going to have a discussion on the topic without which no NEET PG examination would be asked. I mean, the question on respiratory or metabolic alkalosis or acidosis with compensation, without compensation, along with the anion gap or not, is always provided to you for the assessment in any NEET PG examinations. Sometimes it is easy, sometimes it is very much confusing for the students. Let's decipher it by a step by step approach to reach the final diagnosis. So, here is how the questions are usually kept. A 68-year-old male with a known history of smoking presents for the routine follow up. He reports a stable but persistent shortness of breath on exertion and a chronic cough with sputum production. Denies any recent increase in the symptom, fever, or chest pain. Medications include inhaled bronchodilators and corticosteroids. And for these kind of the questions where alkalosis or acidosis is asked, ABG findings will always be provided to you. Here, the pH is this, partial pressure of carbon dioxide in the arterial blood examination is this, the bicarbonate levels are these, and the partial pressure of the oxygen is this one. And on the basis of this, we are asked to identify what is the diagnosis. Is it respiratory acidosis, compensated or uncompensated? Is it metabolic alkalosis, or is it respiratory alkalosis? So, without wasting any time further, let's talk about the step by step approach. So, first of all, what you should always be knowing are the normal values. The normal values which will never be provided to you in any question that you should be knowing about. The pH. The normal pH is 7.35 to 7.45. Now, this is something that every one of you are aware of. Then the partial pressure of the carbon dioxide in the arterial blood gas examination, it is 35 to 45 millimeters of Hg. Then the bicarbonate levels are 22 to 26 milliequivalent per liter, and the partial pressure of the oxygen, the normal range is approximately 80 to 100 millimeters of Hg. No, so these are the normal values which every one of you should be aware of, because on this basis only you will be able to identify whether the patient is suffering from alkalosis or acidosis, right? So the first thing in the step-by-step approach for making the diagnosis is to determine the pH. The pH values will always be provided, as we have just talked, that the normal values are 7.35 to 7.45. If it is less than 7.35, it is acidemia. If it is more than 7.45, it is alkalemia. Second is now to find out the reason behind this acidosis or alkalosis. You see, if the partial pressure of the carbon dioxide is high, then it is suggestive of a respiratory cause to the acidosis. While if the partial pressure of the carbon dioxide is low, then it is suggestive of a respiratory cause to the alkalosis, because carbon dioxide acts as an acid. Similarly, for bicarbonate levels, where the normal values are 22 to 26 milliequivalent per liters, if it is high, then it is suggestive of a metabolic cause to this alkalosis, while if the bicarbonate levels are low, it is suggestive of a metabolic cause to the acidosis. Respiratory acidosis would be identified when the pH is low and the partial pressure of the carbon dioxide is high. Respiratory alkalosis is identified when the pH is high and the partial pressure of the carbon dioxide is low. And exactly opposite is true for metabolic acidosis and alkalosis. Now is the time to find out whether it is associated with compensatory mechanisms by the body or not. For example, for the diagnosis of the metabolic acidosis, the pH values have to be low, the bicarbonate have to be low, because it is the low bicarbonate level which is responsible for this metabolic acidosis. But let us see that whether the body has tried to compensate this loss or not. So as a result of which, the partial pressure of the carbon dioxide should also be low as a compensatory response by inducing hyperventilation. So the patient starts hyperventilating, thereby excreting more and more amount of the carbon dioxide acid in order to bring the pH back to, or trying to bring the pH back to normal. So this is compensatory metabolic acidosis. But how is it different from the respiratory acidosis? In respiratory acidosis, as you already know, that the pH values would be lower because of the high partial pressure of the carbon dioxide. But because the kidneys might need some time for this compensation to happen, in order to bring the bicarbonate levels elevated, it might take some time. So the compensation is always a chronic phenomena. In acute respiratory acidosis, majority of the time it is uncompensated. There is no compensation because kidneys require some time, for from hours to some days, in order to bring this bicarbonate level elevated. So metabolic acidosis can be compensated early, while respiratory acidosis is compensated late. Similarly, metabolic alkalosis is identified by the high pH because of high bicarbonate levels, but the partial pressure of the carbon dioxide here is high because of the compensatory mechanism by the lungs, leading because of the hypoventilation. So this hypoventilation try to conserve the carbon dioxide in order to bring down this alkalotic levels, or in order to compensate for this increased alkalosis. So here metabolic alkalosis is also to some extent compensated earlier or easily. But again, as far as respiratory alkalosis is concerned, which is identified by the high pH because of the low partial pressure of the carbon dioxide. But here also the same phenomena, because kidneys need some time for this bicarbonate levels to decrease. So it is a feature of chronic respiratory alkalosis. That means compensation is a feature of chronic respiratory alkalosis. So what we can identify is that metabolic acidosis or alkalosis can be rapidly compensated, but respiratory acidosis and alkalosis in acute phases are uncompensated. But in case of chronic respiratory or alkalosis or acidosis, the compensation phenomena might be there. Now, as far as evaluation of the compensation is concerned, as I told you that the body will try to compensate, but rarely it can correct the pH completely. For metabolic disorders like metabolic acidosis, the respiratory compensation through hyperventilation, this is how we have just now discussed. While for metabolic alkalosis, the respiratory compensation is through hypoventilation, which is responsible for increased partial pressure of carbon dioxide. So metabolic disorders are easily compensated, while respiratory disorders, renal compensation by increasing, for acidosis, renal compensation by increasing bicarbonate ion resorption, but it takes some time. Similarly, for respiratory alkalosis, renal compensation by excreting bicarbonate, but it takes some time. So that is the reason why respiratory acidosis or alkalosis in acute phases is uncompensated, while there might be a compensation in chronic phases. Now, another thing is anion gap. Sometimes they used to ask about the anion gap, and particularly in the questions of diabetic ketoacidosis, they used to ask about this anion gap. Anion gap basically is nothing, it is the additional contribution to the metabolic acidosis which is unmeasured. For example, if I say, like, if the patient is suffering from diabetic ketoacidosis, right? So, what are the presence of the additional acids which might be seen in diabetic ketoacidosis or lactic acidosis? This is basically evaluated by the anion gap. So how the anion gap is calculated? The anion gap is calculated with this formula, that is the amount of the sodium minus the amount of the chloride and bicarbonate together. All of you know that the normal sodium values are around 135 to 145 milliequivalent per liter, and the chloride values are 98 to 107 milliequivalent per liter. So if these things are also provided to you in the question, then they can ask about the anion gap. So normal, what is the normal anion gap? The normal anion gap is 8 to 12 milliequivalent per liter. But if the anion gap comes out to be higher, it is suggestive of the presence of the additional acids, like as it is seen in case of diabetic ketoacidosis, in case of lactic acidosis. Example over here, the serum sodium values, which is given 140, which is normal. Chloride is 102, which is again within the normal range. As you know, the normal range for chloride is 98 to 107, and for sodium it is 135 to 145 milliequivalent per liter. And the serum bicarbonate is 18, but it is on the lower side. So how will you calculate it? The anion gap is calculated as the values of the sodium minus the values of the chloride, that is 102, and the values of the bicarbonate. So it is 140 minus 120, so it is 20 milliequivalent per liter. And as you know, the anion gap normal is 8 to 12, so it is higher. The anion gap is higher. There is another possibility. You see, the patient is suffering from metabolic acidosis, and there is a presence of additional acids, but it is compensated, it is masked. And why this could be masked? It is because of the high chloride level. Now, just imagine, if the chloride levels are higher, despite the fact that the patient is having low bicarbonate levels, then the anion gap could come normal. So, this is the phenomena which is seen in hyperchloremic acidosis, and it is very, very commonly asked question which is seen in case of diarrhea or renal tubular acidosis. I hope you would be able to calculate, you'd be able to identify the diagnosis of respiratory or metabolic acidosis or alkalosis, compensated or not, with the anion gap on the basis of what we have studied till this point. Now, let's talk about all the findings based on the examples which are usually kept in your examination. The most commonly asked example is diabetic ketoacidosis. You sit in NEET PG examination, you'll get a question on diabetic ketoacidosis. One is on the basis of the diagnosis, two on the basis of the management. So these two questions will always be there. So number one, in a question, for example, if the ABG values are given where the pH values are low, indicating acidosis, partial pressure of the carbon dioxide is low, which is because of the compensatory mechanism, and the bicarbonate levels are low, which is the primary reason for this acidosis. Anion gap is calculated to be higher. So what is the interpretation? So the primary disorder over here is metabolic acidosis. The compensation is low partial pressure of the carbon dioxide. The high anion gap, it points towards the accumulation of the acid, that is ketoacids in case of diabetic ketoacids. Another example that they usually give you is the acute COPD exacerbation that results in respiratory acidosis. Here, the ABG values, for example, are given. The pH is low, acidosis, partial pressure of the carbon dioxide is elevated, which is respiratory acidosis, but the bicarbonate levels are near normal because this acute event is not yet compensated by the kidney. So what is the interpretation? It is a primary disorder, that is respiratory acidosis. The compensation near normal suggests an acute event, so this is not compensated respiratory acidosis. Another example, the vomiting induced metabolic alkalosis. After diabetic ketoacidosis, the most commonly asked question is on vomiting, that how it might result in acid base imbalance. The ABG values over here, the pH is higher, that is alkalosis. The bicarbonate levels are higher, which is indicative of metabolic alkalosis. The partial pressure of the carbon dioxide is also elevated, which is indicative of the compensatory metabolic alkalosis. So what is the interpretation? It is the metabolic alkalosis, and the compensation is achieved by high partial pressure of the carbon dioxide on arterial blood gas examinations. Another example is anxiety-induced respiratory alkalosis. Here the ABG values are higher, which is alkalosis because of the low partial pressure of the carbon dioxide. That means respiratory alkalosis. And the bicarbonate levels are absolutely normal because it is an acute event. The kidneys are not yet able to compensate for this rising alkali levels. So what is the interpretation? The primary disorder is a respiratory alkalosis. The compensation is achieved by the kidneys, but they have not yet had time to excrete the bicarbonate significantly in acute process. I can just hope that you have understood everything related to this acid base imbalances along with the common examples which are kept in your question. Now, if you go back to the question that was kept as a prototype in the beginning of this discussion, a 68-year-old male with the known history of smoking presents for the routine follow-up. He reports a stable but persistent shortness of breath on exertion and a chronic cough with sputum production. So by this time, you have realized that possibly, because not many of the findings are provided, possibly the patient is suffering from chronic obstructive pulmonary disease. Now, he denies any recent increase in the symptoms like fever or chest pain. The medication includes bronchodilators and corticosteroids, which further consolidates your guess that the patient could be suffering from COPD. ABG analysis is being shown over here, where the pH is normal, but the partial pressure of the carbon dioxide is higher. So you can say that, the patient could be suffering from respiratory acidosis, but it is compensated by a higher bicarbonate also. Here, the patient is able to compensate. The kidneys are functional. As you see, the pH is not actually, it is not normal. It is the compensatedly normal pH, which is being provided over here in the question. In the form of the diagnosis, you can reach over here because of the high partial pressure of the carbon dioxide, that means respiratory issues, and high bicarbonate, that means the respiratory acidosis must have been compensated. So answer for that question is compensated respiratory acidosis. Hope you are able to learn one of the most complicated topic in the medicine. All the best for your future examinations. Stay concerned, stay focused, stay healthy and happy. Connect with us on Telegram in order not to miss any update related to NEET PG 2025 examinations. Thank you.